Welcome, everyone, to the final OC3PR for this season. I'm Dave Nilopovitz, and while preparing for today, in many ways, I realized that it's almost back to the start for us. As many of you will recall, OC3PR was started in response to the COVID pandemic and the issues and uncertainties that infectious disease presented. Today, we'll be exploring a similar unknown entity as we will be reviewing viral hemorrhagic fevers and how all of us and our centers can be better prepared for these unlikely but still possible events. For those unfamiliar with Ontario Critical Care Clinical Practice Rounds, it's a webinar series sponsored by Critical Care Services Ontario. Its goal is to help address challenges that health professionals experience while trying to provide the best possible care to acutely ill patients. Our webinars aim to address these issues through education and the sharing of best practices. Its ultimate goal is to help ensure that the care provided to critically ill patients is of the highest possible standards. Previous OC3PRs are available at the CCSO website or their YouTube channel. For today's session, we encourage you to submit questions or comments to the individual named Q&A for question and answer using the chat feature. Today's questions are being fielded by Dr. Neil Adhikari, a member of our OC3PR Executive Committee. As always, we ask you to please keep yourself muted during the presentation. Today, we are exploring a topic of interest and likely concern. News outlets and even Hollywood present alarming stories of Ebola and other viral hemorrhagic fevers. The unknown is always concerning, and today we hope to help all of you in your centers be better prepared to address such entities and begin preparing for such encounters. We are certainly fortunate to have with us today Dr. Rob Fowler. Dr. Fowler is not only an expert, but is truly admirable individual who has actually gone and assisted during numerous outbreaks, including MERS, multiple Ebola outbreaks, including Guinea, Liberia, Sierra Leone, the Congo, and the Marburg outbreaks in Rwanda. Dr. Fowler is a professor of medicine in the Department of Medicine and Inter-departmental Division of Critical Care at the University of Toronto. He is a critical care physician and the chief of the Trauma Critical Care Program at Sunnybrook Health Science Center. He currently holds the H. Barry Fairley Professor of Medicine at the University of Toronto. He is also a past director for the Dalai Lama School of Public Health's Institute of Health Policy, Management, and Evaluation Clinical Epidemiology Graduate Training Program. His clinical and academic focus includes access and outcomes of care for critically ill patients and infection-related critical illness. Our objectives today are to review viral hemorrhagic fevers, including their clinical presentation and outcomes. We will also review current supportive and treatments while also reviewing treatment unit considerations and outbreak readiness in Canadian and global context for viral hemorrhagic fevers. Rob, thank you again for agreeing to present, and I'll look forward to your presentation and our discussion afterwards.
Great. Thanks very much, Dave, for the introduction, and thanks to CCSO for having this venue and for inviting me today. And Neil, thank you for fielding the questions and having a look at the Q&A in real time. I will start out here by acknowledging the land on which I work and am today, the traditional land of the Huron-Wendat, Seneca, and Mississaugas of the Credit, and acknowledge that the land is still home to many Indigenous people from across Turtle Island, and I am grateful to have the opportunity to work on the land and to work alongside my colleagues. The objectives of the talk today are around a review of viral hemorrhagic fevers, clinical presentations and outcomes, review current supportive and specific treatments, and then to review treatment unit considerations and outbreak readiness in a Canadian and Ontario and global context for viral hemorrhagic fevers. And hopefully we'll be able to inject some of the experience from outside of Ontario and Canada into our local environment to help plan and prepare. I have no disclosures other than being an occasional to frequent WHO consultant, for which typically do not receive any payment, and have a CIHR grant that one that speaks to investigating optimal ways of caring for patients with high consequence pathogens in our own Ontario context. So, outbreak settings from the past, influenza, H1N1, circa the end of World War One. These patients that would have been critically ill in any other context are oftentimes in our ICUs these days. They may not have survived in the past, but currently, with the kinds of care that we can deliver to people, virtually all are able to survive. Throughout the last century, the evolution of the ability to provide mechanical ventilation support to patients with severe respiratory infection and injury, and in this case, looking at outbreaks from poliovirus, has allowed us to develop critical care and to develop our ability to care for patients in modern ICUs, where again, we're able to help bring people through illnesses that they would not have been expected to survive in a previous era. And that message is one that I'll convey throughout the talk of Ebola and viral hemorrhagic fevers more broadly. Just again to set the context of we can support people through severe illness. This is a CT scan of a patient that on the left has normal lungs, and on the right has severe H1N1 related influenza in the 2009-10 pandemic. And, this is a set of lungs and a patient that we probably couldn't support through conventional means, but reaching to extracorporeal membrane oxygenation support, we can often get people through such an illness until their own immune system and natural defenses, even devoid of maybe outside specific therapies, can help people get over a severe illness and survive. The kind of support that we're able to give people varies around the world, and outcomes for a very similar illness are unexpectedly or expectedly different depending upon where you live in the world. And we saw certainly during H1N1 that global location was a big predictor of being able to support people through critical illness. If we kind of move attention to other outbreaks, and specifically now on Ebola virus and viral hemorrhagic fevers, I'm going to describe a lot of my experience that stems from experience developed outside of Canada for the most part, working in combination with WHO, and really stems from a period of time I worked at and with WHO about a dozen years ago, and happened to find myself kind of temporarily in the midst of an Ebola virus outbreak that in West Africa that worked alongside clinicians from countries and folks from WHO within the country and outside, and certainly has informed my knowledge base and subsequent practice, and I think some of that is quite relevant to our Ontario context, and we'll draw upon that experience for today's discussion. In early 2014, I was on a sabbatical at WHO and working mostly to try to get a sense of how to better describe respiratory illnesses, infectious respiratory illnesses that had the potential to or were causing outbreaks. And then there was a note of a young person who had died some weeks earlier in Guinea. A sample had been sent to a West African lab and was returned with a preliminary result of Ebola virus, and it had not yet been seen previously in that part of Africa. And so it was a big concern for folks at WHO who deal with these sorts of things on a more regular basis in different parts of Africa, other parts of the world. And as an overview of the kinds of viral hemorrhagic fevers that are out there, ones that we see more commonly would include, probably arboviruses that have taken mosquito vectors like, dengue and maybe yellow fever and, Crimean Congo hemorrhagic fever, potentially depending upon where you live in the world. And much less commonly, things that are not arboviruses, falling into families of filovirus and Ebola, Marburg as specific examples. Hantavirus we see in Canada and in the United States, and Lassa fever typically not, but there are things on this list of viral hemorrhagic fevers that we would want to approach in a not dissimilar way that we may treat and care for patients with Ebola and Marburg, but we're going to focus today more on Ebola and Marburg as a filovirus component of viral hemorrhagic fever. And I've put boxes around the viruses that are ones that we might, not commonly see, but have the um, uh, have an increased likelihood of seeing in returning travelers if there was an outbreak. So Ebola virus, we usually talking about Zaire Ebola virus, occasionally Sudan uh, um, virus, and sometimes Marburg virus. And we've seen outbreaks over the last 5, 6 years of all of these with the potential for a returning traveler. A number of the viruses on this slide don't typically cause illness in humans, even though they may cause illness in other primates and even other mammals. For Ebola and Marburg, the reservoir is typically going to be in bats, in particular kind of bats, that then lead to infections in primates in their environment, sometimes non-primate mammals, that then spill over to humans, resulting in human-to-human transmission that forms the sorts of outbreaks that we have been hearing about and experiencing over the last dozen years or so. If you look at case fatality rates across just Marburg and Ebola virus outbreaks going back into the late 60s, when they were really first described in human outbreaks, at least, mortality has been around 70%. And that is the sort of thing that I think has led to a lot of interest in these viruses and a lot of fear in these viruses, and certainly has been the underpinning of a lot of um, media interest over the last dozen years or so. Oftentimes, these outbreaks for Ebola and Marburg have been in regions of the world that are rather remote, so in the natural habitats of bats and non-human primates that lead to spillover. And oftentimes, the outbreaks have been relatively small in rural areas, but have resulted in a high mortality rate. And it has led to the image that these viruses cause illness that are going to that are going to kill someone, and there's not much that you can do about it. At least that's the starting point for a lot of our epidemiology and outcomes of Ebola virus, and so it leads to a lot of fear. In the West African outbreak in 2013 to 2016, it was really centered at the beginning around the border of three countries in Liberia, Sierra Leone, and Guinea, in a pretty remote part of West Africa, and difficult to get resources and public health to the epicenter of this outbreak, which was instrumental in its spread throughout West Africa over the next couple of years. This is a slide looking at what might be a rather well-appointed treatment facility for a patient with Ebola virus, and this is a slide that I think I took in March of 2014. That speaks to a cholera cot in a room in a cholera treatment center, and oral rehydration solution and water on a cot side table, an IV pole, in the foreground with an IV running. And then on the floor, unfortunately, this was a room where a patient had passed and had passed with pretty severe complications, including a lot of hemorrhagic complications. And this might be an image that is not an unusual one for a place that really had limited resource to provide care and support for people in the hopes that they would get better. In that context, working with some folks at WHO, a small number of clinical people, and this is Tom Fletcher, an ID colleague of mine in the UK, who was there with me on behalf of WHO at the beginning of the outbreak in Guinea, in a treatment facility that encompassed that room that I just showed, working with local Ministry of Health staff and MSF, a small group that had been there to help build out this center, started to care for patients with Ebola in Conakry, the capital of Guinea. And we were experiencing the very beginnings of a big outbreak in a populous capital city that had not previously happened. So subsequently sort of led to a large outbreak that consumed headlines and a lot of news outlets for many months afterwards. A little bit about how this illness begins. There's an incubation period after contact and infection of round about sort of 10 days or so, of which people wouldn't have symptoms, but they would be incubating virus and just preparing to develop symptoms. And the typical symptoms and signs are very nonspecific. So you don't feel so well, you develop a fever, some aches and pains that would be common to many viral illnesses, transition into a bit more of a GI focus with nausea and vomiting and diarrhea and resulting dehydration, and occasionally respiratory involvement, occasionally bleeding and coagulopathy and even hemorrhagic complications. But I say occasionally, meaning it's not so common for most patients. And most patients have a non-specific illness that is very GI centric and very hard in the first many days to differentiate it from many other things, malaria, bacterial, viral infections, otherwise. So difficult at the beginning to have pathognomonic signs and symptoms. There are some that probably are not pathognomonic, of course, but they go along with Ebola. And I've just had a sort of a blown up view of someone with conjunctival hemorrhage, which is common in maybe sort of the mid to later stages of Ebola, and something that I think people would recognize after having cared for a lot of patients. And so there are some things that give you a sense, but unless you are able to do diagnostic testing, it's hard to distinguish upfront what the illness is. And so super important to have an index of suspicion, to recognize some of the signs and symptoms, to recognize where there are regions that might have an active outbreak or be at risk, and then to have a certain degree of clinical suspicion. On the epidemiology, just looking at patient-based factors, there's certainly a relationship with age and outcomes. Those that are the youngest and those that are in a range of age that would include me and beyond do less well. Folks in their teens tend to do best. With higher viral loads at presentation, we typically see worse clinical outcome, and that stands to reason and not surprising. Some of the pathophysiology that was very uncertain when I started seeing patients, for the first time in West Africa and Guinea, it was unclear what was getting people really sick. Why were they dying? From an ICU perspective, what was it that was getting people into organ failure, and what was it that was leading to their death? This is a photo of a piece of paper that we would write down a laboratory exam done in the treatment center with a portable diagnostic testing setup. And just to flag that, of a patient that was in mid-range of their signs and symptoms, they were getting dehydrated with hypernatremia as evidence, a bit hyperkalemic. creatinine in American units quite high, a pretty impressive uh, lactic acidosis and anion-gap lactic acidosis. And I would say, importantly, a hemoglobin level of 105 that would say, they're not necessarily bleeding out while they're getting sick, but they certainly have metabolic derangements that speak to a patient that's been increasingly volume depleted and going into at least a degree of hypovolemic, pre-renal, renal dysfunction, and lactic acidosis. And over, I would say, the subsequent, couple of years or so, a better appreciation of the multi-system influence of this virus, beyond which was appreciated in, the years and decades previously. And, I might want to characterize this as a viral septicemia that has a predominance of symptoms and signs in the GI tract, especially early on, but definitely has features that we would recognize with a lot of non-specific viral illness and bacterial illness that get people sick in our ICUs that require multi-organ systemic care to support organs that are not doing well. In terms of therapies, at the beginnings of this West African outbreak that was so formative in a lot of people's understanding of how to treat patients with Ebola because of the sheer numbers of patients, we really relied on what I would characterize as surviving sepsis guidelines and best clinical care for sick people, and transitioned that information into pocketbooks that were country specific. And this would be the kind of supportive care that you would hope any of our patients to get on an inpatient ward, not necessarily even an ICU in any of our hospitals today for a severe diarrheal illness. Subsequently, we tried to package this a little bit more thoughtfully in critical care journals and general medical journals to describe the sorts of illness that we could see, and then to at least speculate on whether or not outcomes could be better with, we'll say, more resources for care for patients that were sick, like we might see on any given day in Canada. This is a nice reference, I think, that tried to characterize illness and supportive care for this illness using evidence that at the time was out there, either direct or indirect, relating to viral hemorrhagic fevers, and was published in the Lancet. And the bottom line for what we put out in this paper that Francois Lamontagne from University of Sherbrooke had a big hand in organizing is simple stuff. And trying to keep people from being dehydrated, including giving them IV fluids, monitoring their vitals, checking on organ function, having staff to treat people, being able to provide good communication, pain control when necessary, and specific therapies where indicated. This is just sort of motherhood stuff, but things that for lots of reasons were difficult to deliver in many of the settings that people were historically, traditionally cared for. This is a slide of a treatment center that was built out by MSF and WHO in Conakry, and in the topmost part of the slide, in the sort of brown C-shaped building, is that first room that I showed, where we had very rudimentary things on day one, but over the next weeks and months, we're able to build it out with a proper pharmacy, medical supplies, oxygen at least, and a staff that was able to assess patients on a regular basis and ideally prevent them from getting sicker because of neglect or inadequate attention to supportive care. And I would say, providing what would be good internal medicine care, or at least, an attempt at good internal medicine care, or good surgical ward care to these patients in Conakry, mortality was a lot lower than what we saw at the beginning of the outbreak, and a lot lower than historical norms, with huge credit to Ghanaian clinicians that were able to, provide great care to patients in this particular treatment unit. Over the course of that outbreak, over really 3+ years, the cumulative mortality was just under 40%, starting from about 70 to 80%, and then falling over time. And one of the things that I think was recognized, difficult to prove, but with increasing experience and exposure in individual treatment units, mortality seemed to drop over time. And again, this relationship is a bit tenuous, but with more experience and better systems of care for patients, care seemed to improve and patient outcomes seemed to improve over time, which we definitely saw in terms of case fatality rates over at least the first couple of years of this outbreak. Sort of leading to the question of what are the limits of increased levels of care. If we can provide care best as we're able in endemic areas, and if we're able to provide care for these patients in areas that are typically even better resourced. This is a slide with two colleagues of mine that I worked with in Sierra Leone in a place called Kenema Hospital that was the existing Lassa fever treatment center in Sierra Leone that was converted into the place that all of the patients in the country that were diagnosed with Ebola would come. And in the foreground is a nurse, Will, who was a UK nurse that was in the region and helping to provide care for patients, on his own accord. And in the background is nurse Nancy, who again was a Kenema native and had worked in this treatment center for a long time. Both of them, just as I was there and exiting the treatment unit, got Ebola. And Nancy stayed in Kenema for her care, and it was a pretty resource challenged place at that time in the late summer of 2014. And Will was taken to the UK to the Royal Free Hospital in a military transport plane. And you can imagine that one survived and one didn't. And Nancy passed away there in Kenema, and Will recovered with the care that he received, and continues to be a great colleague and healthcare worker today. In trying to characterize outcomes of all of the patients that were transported from West Africa to other countries that had a different level of resource, you see a stark difference in clinical outcomes. In a paper that Alex Lewigdowitz helped lead with a number of Canadians that are listed in the author list and photos below, mortality of 18.5% in a relatively small number of people that were transported to the US and to Europe, but such a striking difference from the baseline mortality of about 80% leads you to imagine that there must be something that supportive care can do to treat patients. And again, this is in an era where really there wasn't much, I would say, specific therapy, just good supportive care. Eventually, in West Africa, in the outbreak, there, with help, was the standing up of treatment units that could provide what we might consider more routine elements of critical care, and so an ability to do diagnostic testing, to infuse fluids, even blood if necessary, although not commonly necessary, to monitor vital signs on a routine basis. And in very rare instance, able to ventilate people and to perform dialysis in the form of CRT here. And so you have an inkling that it's possible, even in a resource challenge setting with a lot of help. And we started to, I would say, turn the corner on thinking of what we could do for patients with historically a dismal outcome if we were able to bring care to patients. And I think all of this has very direct relevance to the potential for caring for patients here in Ontario. Targeted therapy is something that has been just, I would say, amazing to me, at least, to experience over the last 7 or so years. I was able to participate in a WHO guideline process for a specific therapy for Ebola and Marburg virus disease. And the main trial that informs our contemporary knowledge base on what works as an antiviral in Ebola comes from one trial that was run in DRC in 2018 that was able to get a randomized clinical trial going with exposure to 3 different monoclonal antibodies and one antiviral remdesivir, and 2 of the monoclonal antibodies showing a convincing and dramatic reduction in absolute mortality from a baseline of about 50% to about 34, 35%. So specific antibodies, in this case to Ebola virus, that are able to help drive down virus in the earlier phases of infection and to get people through illness and to dramatically improve their survival. And so this would be considered standard of care, at least for Ebola virus outbreak as of 2025. I wanted to mention vaccination and start with just an immune response, which is probably typical to most pathogens and most viral illnesses, where initially there may be some innate immune response, but not so effective. A period of viremia, and then the development of a humoral immune response, and then cellular immune response that is going to take some time. And so the principles of trying to treat patients with a bad viral illness being for sure to give them good supportive care, to try to give them antivirals and or monoclonal antibodies in this case to provide some coverage during that gap period and to drive down viremia and ill effects. And then on vaccination, to try to expose people to a mechanism to left shift the immune response curve to a place that provides protection in this gap where people are very viremic. There is Ebola virus vaccine of a couple of different varieties, which was used in the West African outbreak in the later stages, and then used in large outbreaks subsequently so, and that has been found to be very effective. And I'll just list a couple of papers from the New England Journal that outline the immune response, and I'll summarize in yellow highlight here to say very effective immune response in terms of antibody generation to available and different formulations of Ebola virus vaccine. And when used in ring vaccination among contacts and contacts of contacts, an impressive reduction in the risk of acquiring illness in vaccinated people, and a response that is increasingly effective the number of days post vaccination. Risky period being in the first probably 10 to 14 days or so, and then a very big risk reduction subsequently as vaccination has been taken up and has generated an immune response before and or concurrent with seeing the virus. So very effective way to vaccinate against Ebola. Not something that is commonly done in Canada for lots of good reasons, but something that is increasingly common in endemic areas. And I just wanted to make the other point that even amongst people that contract Ebola and so develop signs and symptoms in the clinical trial that showed effectiveness to monoclonal antibody therapies, if you had been vaccinated before, again with a varying sort of time course, your risk reduction was halved again of mortality just by virtue of being vaccinated. So even if you get Ebola, if you've been vaccinated before, your risk of dying is substantially reduced. And so lots of reasons why it's good to consider different approaches to treatment, including vaccination as a treatment assist. Some challenges for us as healthcare workers in the environment, and I wanted to highlight a few things. And there are, lots of environments that we treat patients with Ebola, from the very rudimentary to the much better appointed in endemic areas. This is one of the one of the buildings in Catamount where I worked in 2014. And again, cholera cots and big open areas to treat lots of patients and common common therapies, rehydration, oral, enteral, antibiotics if people were subsequently infected with other things. Antimalarial is very important in the area. And the business about what's difficult for us in providing that kind of rudimentary care is often the environment. It could be hot and humid, but then by virtue of wearing PPE, as we all experienced during COVID, depending upon the kind of PPE you wear, it can be tough to provide care for a lot of patients for a long period of time. And the importance, especially in endemic areas, of improving our ability to bring care to patients by improving our ability to be in the care space. And that chiefly involves having PPE that's tolerable, doesn't allow you to get overheated or dehydrated yourself. In a project that we had done locally to look at the ability to provide some components of critical care to simulated patients in either hot and humid versus not so hot and less humid conditions, in collaboration with the Canadian forces at DRDC in Toronto, using funds from CIHR. I would say the message that we would bring out of that experience of trying to put in IVs, central lines, and intubate mannequins while dialing the heat and the humidity to a certain amount is that tasks took longer generally in hot and humid conditions, and there were way more health assessment triggers and breaches in best performance of healthcare workers when you are in an environment that is not comfortable. And I think speaks to an importance of trying to make sure that as we develop ways to care for patients, it certainly, high consequence pathogens like Ebola, but also could be, any new and emerging infection, that we're attentive to how we're able to set up the environment to best care for patients by caring for ourselves at the same time. A next project, and I'll just flag because it's something that we don't have available yet in most of our care areas, but trying to say, what are the best kinds of PEP for certain kinds of infections. And this is a next phase project that will help others examine PPE that's reusable, that has better temperature and humidity control, good mobility and field of vision, and a way of communicating to people that is a little bit sort of better than being totally wrapped up in PPE without any visible components of your face, and without an ability to spend as much time as you might want with patients. And so this is sort of future looking, but we can probably do better with respect to the kinds of ways we set up our environments to treat people. I wanted to flag that there are infection prevention and control guidelines for Ebola and Marburg virus disease that exist from WHO convening of lots of experts a couple of years ago. And a bottom line from this document, for me at least, is the meticulous attention to our usual procedures for infection prevention and control, and in particular for contact precautions, really focusing on the ways that people get Ebola virus. It's by bringing virus to your eyes, your nose, your mouth, i.e. mucous membranes, and very rarely, bringing it into contact with your blood. And there's, a few specific caveats, but generally doing what we usually do and doing it well is a recipe for, protecting yourself for something like Ebola or Marburg. If you can prevent getting Norwalk in treating a patient, then you should be able to prevent transmissions in the healthcare system of either of these conditions. from that document a whole host of recommendations. And I bulleted like a busy slide, but I put some highlight and boxes around just a few things that emphasize covering your eyes, your nose, and your mouth in appropriate PPE with a face shield or goggles and a mask that is able to withstand a bit of humidity. Um, uh, Typically two pairs of gloves, and this is coming not from my sort of personal view, but from this WHO document that I would say helps to balance protection of healthcare workers and providing care to patients in a very reasonable way. Um, and a couple of boxes at the bottom of this slide to say that we should be attentive to patients and their severity of illness as they come into triage. We don't know what they have, but many need immediate care, and we should make sure that we're prepared to deliver that, and that we should also make sure that our environments are able to facilitate interactions with family and visitors like we would for any health condition. In terms of treatment unit design, there's just from this past year an Ebola and Marburg Treatment Center guidance document from WHO that I think is helpful in principles, even though it is geared towards resource challenge settings. But I wanted to flag the reference because I think there are many important lessons to learn. And there's a spectrum that I had showed up front of an old cholera treatment center to an example in the Royal Free Hospital where you have beds that are essentially sealed off with ways to get into that space from the outside. That one of my colleagues, Will, that I mentioned, was treated with, to places in North America and lots of places in the world that are in very highly resourced spaces. And this is an example of a place that I visited in Emory that cared for a number of patients that were repatriated to the United States that had Ebola and was helpful at helping people survive and recover. And a schematic of that treatment unit that is reasonably I would say, to scale. And I've put a couple of bullets here that are my own, but emphasizing the ability to provide all levels of care in one area to avoid moving people around an organization, to have good line of sight and communication between the outside and the inside, if you want, for patients and healthcare workers, ability of family to visit patients, either directly visit in a facilitated way and or with communication and lines of sight, to design treatment units and or caring for suspect patients in any of our hospitals that minimally disrupts the rest of the hospital functioning, and that then deserves attention to be paid to kind of where patients are and the ability to, again, minimize the impact on care that's essential for other people. And put lots of space. So I've never come across, I would say, treatment unit or wherever it is where you have too much space, and that's for patients and staff and donning and doffing and storage. In the Emory example, they took in a number of patients with Ebola, and they had all the contracts in place to handle and dispose of waste that accrues at a pretty good clip when you're treating a number of patients. And this could be PPE, or this could be lots of materials in contact with patients. And I asked them, while they were caring for a few patients with Ebola, what are you able to do with your waste? And said, good question, and went back to two rooms that looked kind of like this, and they were full of waste. And they had not been able to convert the contracts that they had into someone actually coming to pick up equipment and waste and taking it someplace else. And so it was accumulating on site because when the rubber hit the road, if you want, people were not so keen to come and pick up medical waste for Ebola. And that took a lot of sorting through over time. And I'm sure the same thing would play out in one degree or another in lots of our environments. Last year, end of the year, there was a Marburg virus outbreak in Rwanda that I was able to attend and was in the hospital that the country appointed as the treatment center. And this was a highly functioning hospital, all of the things that you would want in a hospital. And they said, this is our Marburg treatment center. And so patients were able to get critical care, intubated, ventilated, dialysis if needed, lots of monitoring, and lots of folks to care for patients in real time. And again, not great cause and effect, but mortality typically in the sort of 70s% became under 23% for their outbreak. And so again, giving good care to people, being set up to do so, makes this an illness that is quite survivable, and in the range of outcomes that you would say resemble severe bacteremia, not even necessarily sepsis in our ICUs in a Canadian context. One point about conditions in returning travelers as a finish up. This was a really nice study that was done, led here in Toronto by Andrea at UHN, looking at the era of returning travelers during the West African Ebola virus outbreak, and saying of people that came from the region and had illnesses that would be, febrile illnesses, diarrheal illnesses, etc. What did people actually have when people were worried that they might have Ebola? And nobody had Ebola. And everyone had something else that needed treatment. And by and large, it was pretty severe malaria or upper respiratory tract infections or forms of enteric fever or bacterial infections otherwise. And I'll say they all needed care. And none of them had Ebola. And the point being that it's going to be uncommon that we would see these conditions in Ontario. And it's good to have an index of suspicion, but it's as important and very important for the patient to be able to promptly treat things that they much more likely have. And that's not going to be viral hemorrhagic fever. I wanted to flag some of the ministry resources that exist, that there is a hotline that you can call 24/7. I called it earlier today just to make sure that someone was picking up, and they certainly were, that you can ask questions, because these are the sorts of things that don't come up in our clinical practice usually and require coordination and support across the healthcare system. And I'll sort of leave this slide and the following with resources that will be available subsequent to this talk and online that people can go to say, who should I reach out to outside of my local environment when I have a suspicion, or if I'm wondering what to do. And I will stop there, and I think I'll go off screen share. And thanks very much for people's interest. And Neil, if there are any comments or questions or
No
dialogue.
problem. That's fantastic. Maybe I'll start with a few of the questions. You touched on a lot of the issues and concerns that I would have, like the disposing of secretions. I trust the recommendations not to flush, to get it into our system, but how do you clean a room afterwards? Is there any special precautions? I know we're not allowed to use bleach anymore, but I'm always amazed when I look at what's going on in the various countries that you've been in. Obviously, they don't have the same resources that we have, but are able to effectively clean. What would be your recommendations in between for a patient? And the second question I would have is on transport. What would be your recommendation? Keep them there, or call the health branch for guidance on that? So cleaning and transport.
Yeah, on the first question around cleaning, I mean, so as a clinician, number one, I would call and speak to my local infection prevention and control expert and say, okay, what do you recommend? And so I would, kind of center the expertise there. For things that we often interact with as clinicians, one of the common practices in endemic areas for a long time has been the use of varying concentrations of chlorine bleach, as you alluded to, and like widespread use, including the spraying of people that are emerging from a patient's care area, treatment center with chlorine bleach all over, and the WHO, in its most recent guidance document from the last 2 years, recommends against the use of chlorine bleach, and certainly we wouldn't see that in our hospitals on a usual basis, and recommends instead for alcohol-based hand rubs and cleaning. In terms of environmental cleaning, they do go into a fair bit of depth in that document, and I would say, I would go back to that and point people there, in addition to our IP&C experts, to think about based upon what kind of materials we're cleaning and exactly what we should use. And it's a fascinating science around how things can be maintained, like viruses on certain surfaces, depending upon what the surface is and how you should best clean that. Um, and whether it's metallic, whether it's a synthetic material, whether it's wood in some occasions, and there are some nuances there. And so I guess I've answered it speaking a little bit to the things that touch clinicians the most in terms of not using bleach and not spraying, using alcohol-based hand rubs, etc. But there's a lot more detailed guidance that exists. On the latter question around transport, I think that's a very context specific probably answer and approach, and the context being, I suppose it depends a bit on on where the patient is and where you are, and at some level, I think we all have the ability to provide good care to a patient that is suspect to have Ebola or Marburg virus using the same principles of care that we provide patients every day. And again, maybe the consequences are different, but the principles are similar. And for me, I would say, again, if you have an enteric illness, let's say you have a norovirus outbreak that we have all the time. If you can treat a patient with norovirus and protect the environment and healthcare workers, you should be able to do the same for a patient with Ebola using, again, meticulous approach. Super important to make sure that our system of doing that is maintained uh, at the same time that we are able to recognize a patient is sick and to provide appropriate care to that patient. And to be fully attentive to the importance of protecting people and providing perfect IBC, but to not delay care to patients because there is a question about whether they could have something that we're not commonly dealing with. And so I think the huge risk for patients and our system is to delay, for instance, care for severe malaria or bacterial sepsis or something that's imminently treatable because of the notion of we somehow can't or shouldn't engage safely with the patient using our best IP&C practices. Um, in terms of concentrating care in certain places, I think that does probably make sense. And there's going to be a requisite period of sorting out the degree of concern for a patient beyond clinical index of suspicion and whether or not that patient should move from a particular place to another place for a longer period of time. Oftentimes, diagnostic testing ends up happening at the point of first contact we'll say, a hospital, and trying to get our system response to shorten that diagnostic testing period is very helpful both for patient and for the system being able to, in our context in Canada, usually being able to sort of stand down, if you want, as quickly as possible. And I say that, we haven't had a patient with Ebola in Ontario or in Canada. And so important that we rule it out, but also important to recognize that it's not historically at all going to be common.
Thanks, Rob. I'm going to pass it on to Neil.
Thanks very much, Rob, for that great talk. I have a few questions, and just before I get to them, one audience member who's an IPC specialist has mentioned that at least in the local context, they would use bleach to clean surfaces, not spray bleach, but in a wipe form, which I think is consistent with WHO guidance for that particular
Yeah,
surface. Yeah.
yeah.
Can I ask you about the availability of the therapeutics that you mentioned in the Canadian context and whether those kinds of things would be available here or not?
Yeah, good question. Think, I mean, I think the real answer is we don't know, because it's not something that we've really had to enact so much. One of the, of the things that have been tested before, one of the monoclonal antibodies, ZMapp, that had its origins in Canada, and we had in 2014, 2015, a bit of a supply in Canada. Subsequently, however, the two monoclonal antibodies found to be effective and relatively speaking, ZMapp not. And so, those are not going to be so available, and nor should they be, I would say, like in the Canadian context. But it would be something that we would, have as part of a system response, probably to, you know, probably to try to do in real time. And I've experienced before, that things are again being shipped quickly across borders, sometimes through formal channels and sometimes through efficient channels for patients that are in need. And so that's not really an answer, I guess, to the question. The real answer is I don't know, Neil, and I've not had to ask for it, and none of us have because we haven't had a patient with Ebola locally. And these are not in huge quantity, huge supply, so there'd be some challenges. Vaccination has been available, but because we are not the at-risk population, the resources have been put other places, and that's right. I had an Ebola vaccine as part of a clinical trial a long time ago, and I subsequently have been asking periodically if there's Ebola vaccine available to use for folks that might be going to care for people in outbreaks, and it's not been I would say there's, as far as I know, there's not a clear line on that for at scale. Even though both of those things, therapeutics and vaccination, would be something that at a health system level, people would say, oh, okay, these are important topics. But as far as I know, we don't have a well-tested system in place yet. I think that's reasonable to say, but it's not something that we've tested.
Great. And maybe just one more. If I wonder if you could reflect on sort of, you touched on this a bit, on the diagnostic pathways, particularly comparing the experience with evaluating these suspect cases in Canada and in Ontario in 2014 to 16, as you point out, none of whom had Ebola and most of whom had malaria, and a couple of them had bacterial sepsis. But in the process of collecting samples and sending them out, I believe it was to Winnipeg at that time. Is that, to your knowledge, is that process a bit more streamlined now, or does it still involve send out to national laboratory?
Yeah, I mean, I can comment superficially, I guess, appreciating that, from our clinicians' perspective, this is not our area of expertise. During the West African outbreak, there were provincial protocols in place to dictate, I would say, very clearly the handling of materials and the process by which to get a sample, both locally and then to the national lab in Winnipeg. Subsequent to that outbreak, some of those guidance documents and protocols sunsetted. And when we had, at least in the Ontario experience, some suspect cases separated by a few years from the West African outbreak, it was again challenging to get samples where they needed to go because the protocols were no longer active and and some of the transport was challenging, and meaning that okay, you knew the tubes that you had to draw, you could package them safely, but then to get someone that was going to transport through sort of to the airport through to Winnipeg, there were just hiccups that resulted in a couple of false starts, for instance. We have the ability for sure to do testing within Ontario, in addition to Winnipeg, much more common than in terms of the ability than we had a dozen years ago, and so that capability exists both locally in Ontario and nationally, and sorting out that there would be locally performed tests with a national confirmatory test is sort of where the conversation that I've heard has been. So we certainly have the ability to do local testing. In one of for one of the patients, it became so difficult to get a sample to Winnipeg that Winnipeg came to Toronto, with portable testing to do it here because it was just faster. And that's great system response in terms of saying, recognize their challenges, we're just going to do it a different way. But I think all of those things, because it's such an uncommon occurrence, it wouldn't be right to say everything's well oiled, but there are processes in place that can be leaned on, and certainly people have capacity to do this locally.
Great. Thanks very much. No further questions from me.
That's great. I think we're up at time, so I just want to encourage all of our listeners to fill out the survey. That you can find it in the chat and provide us feedback. It's very welcome and helps us plan future events. Rob, I just want to say thank you for a fantastic, very comprehensive discussion, and certainly thank you for what you do. And it certainly is admirable, and we're lucky to have you in our country. I also want to thank everyone for listening and participating in following OC3PR. And finally, want to thank the CCSO staff who go above and beyond to bring these to everyone. And just want to wish everyone a good holiday break over the summer, and hopefully everyone gets some time away to help rejuvenate. And we always welcome feedback and comments, and welcome that, and just wishing everyone the best. And again, Rob, thank you for a fantastic presentation. All the best.
Yeah, thanks for the opportunity, and thanks for the CCSO and ministry and supporting this work, and the plans that they're building on to help the system response. Appreciate that.